All right, hello. Welcome to another Down Fracture podcast, a podcast for talking jaws. Per usual, Dr. Michael Wasson of Arizona Jaw Surgery here with Dr. Sam Bobek of Seattle Jaw Surgery. Sam, what's up, man?
Not much. Just recovering. So I think my voice sounds as bad as it did last week. How are you doing?
It's not too bad. I mean,
Oh, good.
your face definitely distracts from everything else being terrible.
Yeah, the filter, I wanted an opposite filter where you just blur me out and then you see the background, but technology's not there yet.
It's not AI. It's not gotten us that far yet. Well, as always, we did have some email correspondence last week. Feel free to email the podcast at downfracturepodcast@gmail.com. We got some interesting insight. Someone certainly chiming in and saying that you should be using two screws instead of a single screw for your SSO fixation, which immediately, of course, made me like this individual. We got some more topic suggestions, but that's neither here nor there. Do you want to introduce our
Yeah, we
guest
have a
with
guest
us
today.
today?
So yeah, a guest. So Sophie's here. She's Sophie Cohanim is an orthodontist in Seattle. She's a new orthodontist. Just graduated at the University of Washington orthodontic program, I think 2 months ago,
Yeah,
1 month ago, just recently.
yeah.
And so I met Sophie because I work with her dad, who's an orthodontist that practices in Seattle, and she joined him, I think part-time or
Yeah,
I think
part-time is
part-time,
better.
open up her practice. And yeah, I thought she'd be an interesting person to have on just to kind of have a different perspective of the whole surgical orthognathic process. Because you're pretty old, Wasson. I've been noticing, and I can see that today actually, that you're even older than I remember. And so, like having some fresh eyes on the take on, how does it seem like getting into practice and, what kind of concerns and that sort of thing. So I'm glad that Sophie is able to join us. So thanks for coming on today.
Yeah, thanks for having me.
Um, so let's see. So you just started practice a couple weeks ago. How's it going?
It's going pretty well. I'm part-time at my dad's, and then I'll be covering maternity leave, part-time for another orthodontist in Seattle. And kind of just getting my feet wet, meeting the people that are on the area because I've been fairly familiar with everyone who's from UW, but I hadn't really gotten a chance to spend much time in Capitol Hill in the area. And so meeting the people here, starting a few cases, and then yeah, just kind of starting to see patients in private practice setting, which has been really fun and just so different than residency.
Yeah, that's what I was gonna say. It's got to be pretty much the same, right? Like ortho workups at the university versus ortho workups in private practice. Same.
No, that's the same. I think it's funny. I think the thing I feel completely prepared for everything to do with ortho. I was expecting a little bit more imposter syndrome. It's been mostly pretty good. I'm learning that the only thing that's phasing me these days is the practice management side, which is so completely new, and I had not given really much thought to that area. So
Yeah,
that,
I don't think you ever learn that. I feel like you get better at it, but that's, they call it practice for a reason, right?
yeah, that's true. That's true. Yeah. So we have a really good course. Heather Washington teaches it, and has different guest speakers come. So we do get some exposure to it, but I think it's such a different thing of like I was so deep into like I want to make sure I'm good at ortho and like good at, treating patients in that way. And then I'm now like, I really got to look up these old practice management lectures and figure out how the rest of the practice part works. So that's been, I think, the part that's I'm almost like newer to, but the ortho treatment is still it is very similar to what we learned at UW so far.
Yeah. So let's see. So your practice at UW, at least in ortho practice, wasn't like your first intro, right? Like growing up around orthodontics and your dad and stuff. Did you get any exposure with that, or what was your
Yeah,
life like prior to that?
no, yeah, I did. I also think I took an interest in it. Like I have siblings and I don't think they were necessarily as like tuned in or honed into it. So I think for me, I got the exposure maybe because I was able to, but I also think that I gravitated towards maybe ortho, but also just like healthcare in general early on. So I would either spend time at my dad's practice, I would like ask him questions about cases, or he would show me cases. And I got to see a lot of pretty interesting stuff. Even just like I would say going like before dental school. I got to hear about him treating maybe some cases of like I like sleep apnea with double jaw surgery, like you know, back kind of in the earlier stages when they were saying like, okay, does this work? Does this not? Is there evidence? And kind of getting to see like I remember my stepsister up close had jaw surgery, and so I remember getting to see that up close was pretty interesting, especially since she was home with like me and with our like
How
family.
long ago was that, by the way? Like ballpark? 10
I
years ago?
ballpark, let's see. I had to do math on how old I am. Probably like 15 years ago-ish, I want to say.
15?
Yeah, I was in high school,
Yeah.
maybe middle school, but I think like early high school.
Does that math work out? Anyway, let's say 15. 15 years,
That's
jaw surgery
yeah,
can be different in 15 years. In ortho, like because my perception is ortho is quite a bit different in 15 years. Or is that, what do you think about that? Like,
no,
what do you
I
think?
think it is. I mean, honestly, I think actually one of the cool things about getting to learn from my dad was he did Invisalign pretty early on, so I was hearing about it, but I think now it's so much more mainstream, and even things like would come up in like in our like the surgery seminar, if you remember, Mike. I'm pretty sure they still had it back then, but they did not back then, but they did. We would always have like these seminars with the ortho surg residents, and one of the things that came up a few times was like Invisalign and orthodontic surgery, and how some surgeons like really don't like it, and they were kind of the surgeons teaching them were kind of like, you're gonna have to probably adapt to this because so many patients come in requesting and like really wanting Invisalign. So that was one of the things they would bring up in surgery seminar often.
What'd they do in surgery seminar? Watson, when you were sitting there, because
Oh man, it was I'm gonna be honest, because really, I'm a 50% owner of this podcast and I feel like I can say whatever I want. It was painful, man. It
so you're
was,
talking surge ortho
yeah, it's
conference
in this
20
dark room. It used to be on a Tuesday morning,
2010.
maybe Wednesday. Yeah.
Okay.
So the information was phenomenal. Like I wish I could have just gotten like a handbook of it. The people who taught it were very knowledgeable. They were very experienced. They had lived this stuff. It wasn't just people who did a literature review. Like the information was good. But from the oral surgery perspective, it's like this dark room on a Tuesday morning, half the place is post call because we cover 4 or 5 hospitals, and they just turn off the lights and it's so monotoned. And I mean, it was a struggle to fall asleep. I mean, to just stay awake was a struggle for most of us, but it
Yeah.
was very useful information. But it was, the surgery mindset. I felt like we took 50 minutes to probably give us what could have been a 10-minute, 15-minute conversation. And it was
So
brutal, man. So
did it
that's
get
my
better
perspective.
as time went on? Did it get better?
Me or
No,
her?
you, the conference. Because you weren't
I
attending conferences at the same time. So like, in 2022, let's say, or something like that, was it a similar experience or was it updated?
No, that actually sounds like nothing has changed whatsoever. And I don't want you can edit this out if you want to, but I would say there were definitely at least one or two surgery residents napping each one, and they were the post-call residents. So
I think if you don't get sleep, it's just called sleep. It's not
yeah,
napping. Like
no,
if you're
that's
up all
true.
night,
Yeah.
you're just, that's your
Hopefully
45-minute sleep.
praying for REM a little bit. Yeah, no,
Yeah.
that sounds exactly the same. And I'll say, to be honest, even same, like I mean, we were not as sleep deprived as you guys, but there are so many times where I look back and I'm like I want yeah, I wish I had a handbook. Like some of this information would come up like as you talk about a case, but like I wish I had some sort of like written thing that I could refer back to now, because you kind of like listen, you try to absorb it, and now like there are times where I'm like, man, I kind of want to like go back and see if I could get like just a spreadsheet of everything and kind of be able to refer to hear it, because it was really good info, and the people that taught it, I think probably the same for you, but like Dawn June Dale Bloomquist, who like retired I think right after my class, and I feel so lucky to have gotten to have them because they're brilliant. And Dawn was the orthodontist and Dale was the surgeon, but it was really good information, and it was cool to learn from them, and they were so in sync, the two of them.
Right.
So I think that was also really good to see
Yeah.
as
There
a
was a second orthodontist. So it was those two and a second orthodontist. And then again, to me, it's the one thing I wish I had understood more, because I'm always asking myself that, I wish I knew what the orthodontist wants. And there's, having now practiced in a few different regions, I find that it's geographically and individual provider differences, but I wish I had a better understanding of that. But it was almost all orthodontic driven. It wasn't like, Dale maybe gave like 2 or 3 lectures over the course of the year
Yeah,
out of the
that's
like 45 or 50, and then it was otherwise orthodontic lectures, and it wasn't real case based. Like it wasn't like, hey, we're working on this case together, let's look at it. It
oh,
was like really lecture oriented. And I mean, they would show cases, but it wasn't like, here's, what I would have wanted was, here's this case. Here's what I, as the orthodontist, want to know. Here's what I, as the surgeon, want to know. How do we communicate? What if we didn't do this or did that? Or, I didn't feel like there was much of that. I felt like it was, I mean, truly like you were in a lecture hall and back in dental school. And it was just,
So
man,
it's
I just want to go curl up in the corner right now, actually, just thinking about
a
this.
little PTSD. Well,
Yeah.
I guess in that way, then I think it actually has improved because the one thing I'll say
nice.
is we did get, it was actually, we got a few lectures, but it was mostly cases.
Oh,
So
that's great.
that, I mean, there were definitely lectures, but I think that part was really nice. And you would get to see how they treated and like what, there, if something came up, they would talk about, how could we have done this differently or what should we have communicated on better. So actually, I guess in that way, it was, really valuable. And I mean, there are times that I kind of wish we had more lectures, but I think that's just grass is always greener. And it was kind of this thing of like,
Yeah.
we
'Cause
had, I
it
think,
was,
enough to get us like to the point where it wasn't going to go over our heads. So that was good. But there were definitely things that like later into seminar, I would get more out of what looking in a case at like compared with like the very beginning, which I think just comes with time and learning. But
yeah, because
Right.
on at Oregon, ours was kind of similar in terms of there's so much going on that you're just there. And honestly, the resident that had to present on the surgery side would frequently not have been the resident that was on rotation doing the surgery. And it was like, I like going to this conference, but I don't have any continuity of care.
yeah,
And I think that's actually a big struggle on the surgery side, heading out of residency to real orthognathic practice is, you have experience doing the surgeries, but you don't have experience following the patient throughout their
No.
care, which orthodontists do have that training, right? Like I at least perceive that.
no, we definitely do because and actually it's funny you say that because now that I think about it, I would do a lot of communicating with not the residents, but the attending that was going to do the surgery.
Yeah.
I almost never emailed the residents directly. It would be, I don't know if like Dr. Laying at UW would be emailing me and saying, hey, this, XYZ happened today, or we saw this patient today. And we would go back and forth, but I don't even think there was a resident that was like CC'd or anything that was like that I remember. Because man, I don't know if that's because it was just, they might have been there. They don't know who's going to be there during the actual surgery or not, but we did have like maybe some moments where we would talk about a case if we were going to both present the same one the same day, something like that. But yeah, we get a lot of continuity because they assign you your patients at the very beginning and you stick with them throughout ortho because it's tough to jump around with the
It's,
with that. But
I mean,
yeah.
I'm always like ways to improve communication between surgeons and orthodontists. And I'm a little bit suspicious that this core way we learned how to do jaw surgery from a residency training standpoint, we never even learned the communicating part of it because this is all happening behind the scenes. Because from your perspective, talking to the attending seems like the right approach. Like that's definitely the right thing to do.
Yeah, and I guess there are times where like honestly, I think Ruse might have talked about it in his lecture, but like we have a lot of like communication with the other specialists as far as like perio, pros, like endo if that comes up, but like then you're directly communicating with the other residents. So it's like perio resident to like ortho resident, for example. And that's great, but then I guess has its own challenges, but you do learn from it. The challenge maybe being that if something comes up, you do have to each go to your specific attending. And I think the joke is like it's my dad has to talk to your dad later on or something like and kind of going back and forth. But yeah, like for the surgery residents, we didn't get to do like have that practice, I guess, to talk together. It was me kind of going with the attending, but letting them take the reins because they were the attending and I was the resident. So it wasn't two people in the same spot. It was, yeah, I guess me reaching out to attending, but I definitely learned a lot from it. But yeah,
So as you get into practice, you're going to see a jaw surgery patient at some point or someone who's like at least might benefit from such a thing.
yeah.
Like how are you going to approach it in the same way or how have you come across this yet, or what do you think about that?
I haven't come across it yet. So I actually I'm excited to. I'm like ready. I'm like very I would love to, but I've so far seen I think a couple simple cases and then like some kiddos. So I'm not quite ready for jaw surgery, but trying to think, I guess the way that we approached it at UW was probably more you'd see the patient if you felt like surgery was on the table or like you kind of wanted them to explore that option. You usually they hadn't seen a surgeon first. You were referring them off to the oral surgeon. There was a longer wait because it was kind of that Medicaid like state insurance, so that maybe didn't happen as quickly as it might happen in private practice. But once they talked to the surgeon, there'd be some correspondence back and forth of like, I do think this is a good plan. And at that point, usually I would, we would be referring for surgery and I would have some idea of like, I think I want single jar, double jar. That's what I'm leaning towards, but I'm looking to see what the surgeon will say and what they will kind of lean towards as far as what they think the best outcome is going to be. And that was kind of the like what we would do.
Because yeah, I think I mean, again, I see it on the surgery side, but on the ortho side, I've always thought it's hard to present surgery like that, right? Like,
Yeah.
you need your teeth straight. I'm bringing my kid in, who's 15. I got, crooked teeth, and the dentist told him go see Sophie. And so then Sophie's like, hey, you need jaw surgery. And then all of a sudden it's like, holy cow, this is getting crazy. Did
Yeah. People's eyes get a little wider as you talk and yeah.
Because I mean, it is different if
No,
you're talking to patients who aren't Medicaid, or, like if it's like a different group of people, to kind of like understand the benefits and everything. I mean, your dad probably's got you ready for that though.
yeah, I think, and maybe it's because, again, I think maybe being able to say, like, hey, I saw my sister go through this. It's, it is a bigger surgery, but it's, it's doable and it's got a great outcome on the other side generally. And so I think I'm sure it's going to be different than the Medicaid patients. And I guess being fresh out, I haven't had too much experience with that quite yet. But I know kind of my approach, even at school, because we would have to, see these exams on the fly. And if you had surgery in your head, you kind of wanted to maybe broach the subject, but not necessarily go into too much detail. Just get them comfortable with the idea that you're, thinking that would be an option if we, want to explore that route and maybe why somebody would.
Yeah.
And
Because
then,
you had
Yeah.
co-residents and everything. Did you help them out, or did they help you, or were you all equally comfortable with the whole surgery aspect, or?
I guess, I mean, really, there was a lot of I maybe knew, I mean, not too much, or maybe slightly more than the average someone coming in, just because I'd asked my dad a lot of these questions and he had told me a lot of these kind of stories and talked about cases a bunch. But generally I would be helping my big was helping me when she was there. And so that it was kind of this like downward, like just
Or
like more senior resident to a more junior resident.
got it.
Yeah.
Yeah.
And oh, go
I'm
ahead.
sorry. Go ahead. Go ahead. I was just thinking out loud. Go right ahead.
No, I'm trying to think. I mean, I think consult was something that I felt comfortable broaching the subject, and I do remember like some of the residents maybe wanted more like guidance or more of like a like how would I approach this? And that maybe did come from talking a lot with my dad about it early on. And I will say that I mean, I never got too like into the weeds, I would say with the consults because I think that there were certain questions that they would want, surgery is a big thing, especially if somebody hasn't heard it before, for their, like as a suggestion for themselves. And so I think I would often try to say, here's what I know, the experience, but I think ultimately the surgeon's going to be able to answer your questions better. We can go from there, see if this is something you want to do. Kind of like that.
Yeah, Sam, I'm gonna interject here because like you're just throwing out these kind of weak sauce softball questions. Like we have a guest on here who
I'm like,
has
it's nice.
such good information available to us, and you're just like chit-chatting
Oh,
here, man.
well,
Let's get
go
down
for it.
to it,
Get in
man.
the thick of whatever
Ready?
controversial topic you
God.
want to
Here,
dig
let's
I
hear
into.
don't
it.
I don't even want to be controversial. I'm just saying like we've got this fresh out of training person. So here's what we really want to know, because this is a jaw surgery podcast. Like, what
Okay.
are the attitudes towards jaw surgery presented in an orthodontic training program? Because I can remember we were talking about Dale Blomquist, and I remember talking to him during my training, and he would say, Mike, I feel like long gone are the days of the 3, 4, 5 millimeter advancement. He said, I feel like in my career, I've seen us go from doing what would have yielded the best outcome to avoiding surgery unless orthodontics alone couldn't treat it. Is it presented in one or either of those ways, or a medley of those two? Is it very much, hey, you want case acceptance and you don't want to scare your patient away? If you start talking about surgery for a 4 millimeter advancement, they're going to go to the orthodontist down the street. How is that approached in you guys teaching and training? Because frankly, you guys are failing and should be sending us a lot more patients.
This is good information for me. All right,
Man,
let's do it.
that was
So
that was aggressive.
that was not a
That's what I'm
softball
saying.
question.
I mean,
Let's
I don't
get
know if we
into it.
can
All right,
internet smack
okay.
him a little
No,
bit.
I've got
Jeez.
an answer for you. Okay, so in terms of, it's funny that you say that because in terms of some of it's not even just orthodontic surgery, but in terms of orthodontic surgery, I was always kind of told like, the margin of error is such and such that if you're not going to do a big enough advancement, is it even worth it to do this kind of surgery? So, and that's something that
That's totally right, by the way.
is
I
that
agree
Yeah,
with
okay,
that
that's a,
that's
100%.
still okay.
I think it's a great answer.
That wasn't practice management. Okay, cool. So, I mean, there is still like the area of, and it's not even just jaw surgery, but like if you've heard, okay, I guess these might be controversial topics, but if you've heard about like, like the whole, we have like sleep apnea as a hot button topic. There's airway, there's extraction, non-extraction, there's surgery. So, I think you will have some people that'll come in and they'll kind of actually be like almost like interested in things like this, like in the expansion or jaw surgery or whatever it is, because they want to try to like maybe get a chance at treating this apnea or improving things if that's what the root cause is. You definitely do have, I think of it more in terms of extraction, non-extraction as a practice management thing. But it's less, I think of it less personally for surgery, but extraction, non-extraction, most patients are going to prefer a non-extraction approach if you can, and especially because there's all this stuff out there right now, and it's on TikTok even about airway, and if you extract and what's going to happen, you're going to get TMD and you're going to have worsening sleep apnea and things like that. So I think, you'll see people maybe trending more towards, and I know this was a trend back and forth for a while, but you'll see people trending more towards like a non-extraction approach, I would say, if anything, for practice management. I don't think, and this might be personal preference, maybe this is the reason that some people prefer non-surgical over surgical. I didn't feel this way. It might be biased because my dad and just like the way that I saw things growing up. But I never felt like I was leaning towards or taught to lean away from surgery. I kind of always would look and say, okay, like if for me, the way I presented it and the way I think people would come out with their own ideas just based on it would vary based on, the attending or the situation. But if I felt like somebody could be helped, like their profile could be helped by surgery, I would always bring it up. If I felt like, for sleep apnea, what we learned is, it's not a reason to do it on its own, but, evidence supports it. If it's needed, I think it was like 10 millimeters, double jaw advancement was like the only thing that was supported. But that we learned. Um, overall,
You're gonna trigger Sam.
I'm gonna
Sam is
trigger
just like
Sam.
about to explode. I could
Not
just
at
see his
all. I
face.
like everything I'm hearing. I mean, I think when it comes to the thing that's on the ortho side that I think is hard is you guys also get pressure from the general dentist and from the more natural orthodontist. Not natural, but like, like
I know what you're saying.
the
Yeah.
appliance, I
Yeah.
forget the term, maybe it's holistic. There's
Yeah.
some type of orthodontic subset
Yeah.
where instead of using conventional forces, you're going to use appliances and kind of regrow the face. And I mean, I feel like those pressures are probably ones that you'll see a little bit more getting into practice, like for the different opinions.
I actually already have seen a little bit more in practice of people coming in and kind of wanting some, expansion for like or a holistic. I actually wasn't even sure what this meant at first, but kind of a holistic approach for their treatment. And I was kind of like, okay, I gotta, looking to see what you're kind of looking at. But that I have seen a little bit of just in my brief few weeks kind of
Like,
here.
where do you go to get information on orthodontics? Do you read the American Journal of Orthodontics? Do you have
Uh,
a printed version of that at your desk where you're
I
like, I'm just going to read?
I would say no. It does come in the mail. I will sometimes read there. I think I probably go online more. I have the subscription, so but I will go
But
to.
are you following TikTok then to get info? I mean, honestly,
No,
like
I would say
it's
no.
not
I would say
offensive.
no TikTok there. I would say for me so far it's been study clubs and things like that. So I had one. I mean, my dad has one that I've been going to for a while. I've been to some through friends that have invited me, different specialists will put on, or, you know, I'll go to, I think, the Invisalign courses. And so far, I do feel like UW prepared us really well. So as far as that goes, I think, you know, I feel like I have a nice, great like base of current knowledge. And then I'm trying to supplement, you know, like, do I want a little bit more aligner? Or do I want, for me, like surgery, like learning, you know, how this is done in the real world and how you guys kind of like to set things up is really kind of exciting for me. But overall, I feel like I have a good base, and now I just want to keep myself current as much as possible. The other one that is I don't know that you guys would look at it. I think it was like Keith O'Brien's blog. There was one that's like people, like a lot
Is
of
his
ortho.
first name Kevin?
Yes, Kevin, that's it.
Yeah, I've seen that.
So that one, and I think that is something that I'm now kind of newly getting into is like, okay, I'm no longer in school hearing the most current things or talking to other orthodontists every single day. And so starting to do that is kind of been a newer thing. But I would say it's not TikTok. And it's also I think getting into like AGO DO more often is gonna be something that I'm gonna have to, now that I'm no longer in school, is gonna be something I'm gonna have to keep up with a little bit.
Yeah, I
Yeah.
mean, Wasson gets most of his education from meeting people on this podcast, I think, right? I mean, in
Let's
between,
see.
It helps.
Yeah.
It
I learn
helps,
a lot
man.
from it. I mean,
I do too.
it's getting into practice and continuing to get up-to-date info is a little trickier than it might sound. It's
I believe it.
so that's why I was kind of interested on
Oh.
the current trend of people leaving residency.
No, it's a good question. I think it's new for all of us. I think that definitely for me, the way that I enjoy it the most is stuff like this. But like some one of us has to have something to bring to the table. So I guess we do still have to look at these things at some point. But I like talking to different colleagues or friends about just different cases. I think that's the way that I learn the best and enjoy it the most, because you get to see like a real case and kind of have the real
Yeah,
world.
did they take you to the OR? Did you go to the OR in residency?
No, I actually I think they had made things a little bit stricter. I think they do want people to if they can, but they made things a little bit stricter in the time. I think it was after COVID. I've been to the OR with an ENT before just because I was kind of interested and wanted to shadow a little bit. And actually, yeah, no, it was ENT. But I never got to see like an orthodontic surgery. So I've, you know, done my own little, you know, watched some videos, but that's something that I think because they made it a little bit stricter, not everyone necessarily, unfortunately, gets to go.
Yeah,
So
and did they get
yeah,
the oral surgery residence in the ortho clinic or no?
definitely not, no. But
Yeah,
I know you
'cause
guys are maybe a little bit busier than we are.
I don't know. I don't know. I feel like the
I
mixing
couldn't, I
that's
couldn't, I don't
did
think I could
you?
handle it.
No.
No, I don't think I could handle it,
I
man. It's
did that
too
during
just, did you
fellowship. I
really?
thought it was great actually.
I
But
mean,
I wouldn't mind going to a private practice, but like the resident ortho clinic, I think would be, I don't know if I could handle it, man.
a little hectic. I will say
you are so hoity-toity.
It's not any kind of, oh, I'm looking down on them. I'm just thinking back to residency and what was going on, like going and being in a dental type clinic, I think would have been an unusual experience. Like it's hard to characterize, I guess. Maybe I'm just coming across as a complete jerk in this entire episode, which is fine. You can't kick me out at this point.
You're good.
I'm just saying, like, I would have been like, if I was in that clinic, I would be like, I have a million things to do, and I'm just like watching things being put on people's teeth, and
I
I think I would just lose it.
I think you're not. I think you're not alone. It's okay. Having talked off of a podcast to some of those surgery residents, I know you're
Mhm.
not alone. So I promise that's
Yeah.
not new.
Yeah,
Yeah,
I bet you it's
that's
pretty
funny.
similar to you guys going to the OR. I bet you a chunk of ortho residents think like the last place they want to go hang out is in the OR.
You know what? Yeah, and I guess that's again maybe personal preference, because I was like, I can't wait to get in there. Like I really want to, I just want to I want to see and like kind of really fully understand. And because there's so many nuances that I think sometimes you hear about talked about in like a surgery seminar that I would kind of like to, I think it's easier to understand if you really see it happen. But I mean, you know, just whether it was because they were squeamish or just not as interested, would prefer non-surgical approaches. I think not everybody maybe like was dying to go, and so maybe that's part of it too. I will say, to answer your earlier question, I was thinking about this. I think that for the most part, we were never taught to steer away from surgery. I don't think we were taught to go one way or the other, but I think that may be just because we were never taught a lot of the practice management. We were never taught, do this over, we were never really taught the practice management side, I guess. So I think you'd get out into practice and maybe I could see it being that somebody finds that this is a more popular response and it is competitive today. And if, somebody says surgery and the patient doesn't like that, they might leave. I think that might be something that at least for UW find after graduation.
What well, I guess, yeah, I mean, that's an honest answer. And I think that's what we try to have here on the podcast, because sometimes the answer is not clinical, right? It is those other factors of, hey, I've got mom and dad sitting here with their baby boy and girl, and I'm talking about jaw surgery, and it seems almost endemic in the orthodontic community that like free consultations, like I can go get a free consultation down the road with someone else, and if they don't say surgery, I'm probably going to go with them. I mean, I think that's a real part of practice for you guys. And so I would follow up with that question is like, is there any kind of, based off what you said, I think the answer is no, but like, is there any numerical threshold if you guys are looking at a somewhat compensated 4 millimeter, 5 millimeter, overjet or something? Are you starting to think, oh man, by the time I compensate things, it's going to be 5, 6 millimeters. I should be talking about surgery, or if I do IPR here or do this, it's going to give them poor lip aesthetics. Like, I mean, how is the thought process to getting them to surgery? Is there a threshold that you're taught, trained? Is it just individual provider preferences and experience?
I think it's some of all of the above. And I was never like I never thought of it as to us we it's cusp. So it's full cusp class 2, and so you're gonna need to, I guess the millimeters would be 6 or 7 or something like that. But to us it's maybe we just call it's full cusp class 2. And so maybe now we start to consider surgery and they're an adult and they're not growing anymore and there's no, hope that this jaw is gonna come forward a little bit more. And that was maybe one way. So there was never I never really learned like, this millimeters advantage of that would be a surgical case. But I think for me it was always, and for I think what we would learn is okay, we're full cusp. Do you really want to compensate this? And even if you feel like you can compensate it without, compromising the dentition and the periodontium and the health of the patient, can you do it in a way that's going to look good extraorally? Like how's the facial, tissue, the soft tissue going to respond? So I think for me, those were the things I would think about if I, saw a profile and I was like, I really think this would be helped by surgery. I might, if I felt like it could be done either way dentally, I might give them both options, but I might say, if you want to affect the profile, this is the best way. So yeah, I think for me, when I'll start thinking about surgery is when it's like a full cusp, like for class 2s at least. Class 3, might be a little bit different. Again, I think it's less numerical. Definitely consider the profile. We kind of consider, is there a shift? Can they get edge to edge? If I can get them edge to edge, do we think we can get a good response? Or do we feel like, because of the way the profile looks, I'd still want to recommend surgery, or, because this is going to be a heavy compensation and that they're going to be really retrocon. Like I did have, like, I think a patient that I could think of where it was the right move not to go with surgery because they had some other disabilities, but it was, that was a severely compensated case and it was really difficult to achieve like an ideal outcome. And I would say we compromised in a couple areas because we were trying to compensate so much dentally. So yeah, I think long-winded answer, but it wasn't so much a numbers thing. And so I guess that's hard to track over time how that changed. But for us, it was, were they talking about numbers with you guys? Was that kind of how
Not
you?
necessarily. No,
Okay.
I mean, I just wanted an honest answer. I think you gave a
Yeah.
very honest answer. And, how do you guys approach that? Because, I think almost, Sam, I'd be interested in your thoughts on this. I've almost feel like we've come full circle. Like I felt like early on in my career, and granted, I wasn't jaw surgery exclusive at the time, but it was, hey, we're not doing jaw surgery for small movements. It's only kind of big movements. And now I feel like, you see a lot of patients who actually have decent occlusions who are coming to us as the surgeons, wanting surgery for other reasons. And it's kind of been a little bit of an eye-opening thing. I know you go through that, Sam, but I mean, you see that
Well,
a lot,
yeah,
I'm
I
sure
mean,
too.
because depending on where patients come from, I mean, I think the ortho office is, I think Dale's comments that he made to you about kind of more severe malocclusion seems right. Because, I mean, I can't remember when I saw it, but there's the extended envelope of discrepancy, like, the old prophet,
Yeah.
sagittal and coronal view of how far you can move the teeth through orthodontics or orthodontics with assist, headgear, TADs, and then with surgery. And like the updated one, that's probably what you learn now, which is just like they're broader, right? Like what you can carry out with TADs is in theory more. In practice, it might be a different animal, but So yeah, so you're getting more extreme cases from orthodontics, just because, maybe there's TAD-based ortho that can make up the difference in other things, but there's definitely, I think, word is out in other specialties, right? Like in aesthetics, in breathing, um, in physical therapy, or in, like the kind of more orthopedic kind of side of practice, that jaw surgery can play a role. So I think is that's probably what you're speaking to, right? I mean, outside of orthodontic, in terms of referrals, I think that's where it's nice to work with um new orthodontists, is us sending you patients. And I would say for most surgeons out there, that's a good technique, by the way. So if you see patients that need jaw surgery to breathe better, or jaw surgery to look better, or whatever situation, maybe you're repairing trauma, connecting with orthodontists in that way is a really good technique for building your practice. And it's also a good way to just kind of extend your community a little bit, I think. A lot of times people have the practice like you guys are describing, where a senior surgeon and a senior orthodontist have been working together 10, 20, 30, 40 years, and they have such a good working relationship. It's just kind of like you narrow your practice down, and it can be a hard thing to break into as a new surgeon, to work with a seasoned orthodontist, or as a new orthodontist to work with a seasoned surgeon. So I think trying to break those barriers down as best you can is a good idea.
For sure.
How did you approach that, Mike?
With regards to what now
Like
specifically?
getting to work with new orthodontists, or like more seasoned orthodontists, like people who have worked with other surgeons. Because it's, at least, I don't know, I have this perception that like people tend to maintain working with their same people if everything works out okay. Like, hey,
Right.
I worked with so and so, I worked with Dr. Wasson on this case and it went fine, so I'm just going to work with him from now on.
Yeah, I think some of the things you mentioned, trying to send them patients helps. If you're doing trauma and other things like you're saying, sometimes they need a little orthodontics post-trauma, and sending them to an orthodontist can be useful. I really felt what has helped me the most, honestly, is probably like online reviews and the overall favorable view of your practice.
But but do you
Do you know
think,
what?
I mean, to get patients, but do you think that like helps establish care with the orthodontist? I mean, because Sophie,
I
you
think
aren't
a
reading
little
those
bit.
reviews, are you?
Yeah, well, I
Maybe
mean,
you
I
are.
think, what did you say?
Sophie, are you reading reviews for referring offices?
No,
Is that a thing?
I I'm gonna be honest, maybe like a glance at it just at
Oh, all right.
baseline, but I don't think it's the first thing I look at. I mean it's maybe one of the things I look at, but I feel like, and maybe again, if I was in moving to Arizona and starting a practice there versus coming out from, UW and having been like, I had already like maybe through my dad, but also just through UW, like heard like Sam Bobek. That was a very familiar name for me. And so I think you would lecture to our class once. Like I think it was almost like I think maybe just like the small kind of network that you have here that does kind of allow you to maybe have, oh, like this is a great surgeon to work with and they're in my area. Like I'd love to start like kind of reaching out to them and give them a try, if that makes sense.
Let me back up here, because maybe what I was saying, I didn't finish my train of thought there. So we've all had the patient who was referred elsewhere and brings their referral slip into your office and says, "Hey, I I was referred here. I didn't have a good experience there, or I read their reviews and I don't want to go there, and so I made an appointment with you." We've also had the patient, Sam, I'm sure it's similar to you, but I get patients who want to come to our office all the time because all we do is jaw surgery. And so having like practice reputation, I think, has been a good builder, because now the patient is driving a lot of that, of like, I want to go here.
Mhm.
And so then the orthodontist is, I don't want to say forced, but they're kind of put in a bind, right? Like they may not want to work with me. In fact, I'm sure they don't want to work with me, knowing myself. But now they are, and maybe they have a good experience, a good outcome, and that's a way to break in. I think as well. I found that was helpful. Otherwise, you're right. It's tough to, because the whole office workflow at the referring office, we all are familiar with referring dynamics. And you're right, the front desk knows that when the doc says, hey, they need a referral for jaw surgery, they send them to Dr. So and so, and the staff even fills out the referral, and like it's all almost behind the scenes taken care of. And so that's a tough thing to crack into. And so I think those are the things that I've noticed that have worked. You can certainly lecture. I don't know. Do you have any other tidbits you'd say there for our audience of maybe newer surgeons, Sam, or what Sophie as a
Yeah,
new
man, I'd be
orthodontist
interested in
would you be
Sophie's
looking
take.
for? Like, what would you be looking for beyond just maybe a little name recognition or exposure? Because I mean, that's what we want to know.
Yeah, I think honestly, I think I'm trying to think and also maybe be like unbiased as far as like if I didn't have maybe the knowledge that I've had coming into the like Seattle scene, but like I think for me, I always feel like my best experiences, even just for my own care, have been out of referral from another doctor that I trusted. So I think that's, if you do have the luxury of knowing someone around there, that's like number one, is I think, hey, this person's worked with this person, they recommend them. So it's almost like a word of mouth referral. But I do think good reviews are really important. I think I know for my dad would say, if he was trying someone new, he would maybe go to the OR with them once or try to just work like a little bit. I think you guys mentioned it a little bit, but work a little bit more closely up front early on. And if it works out and you guys have a similar style, you eventually get comfortable. And that's, you would continue to work with them. Cracking into it, I guess, is sometimes, yeah, I actually think that one's, I'm not entirely sure how I would go about like looking for someone new beyond maybe like, yeah, looking at their reviews, kind of maybe asking word of mouth if anyone's worked with them before, had, good experiences. And I think that's probably the first line for me.
Let me let me ask you this because I know if we let Sam talk, he's just going to ask something silly. Um, what do you, one thing I struggle with, and I'm sure I'm not alone. I'm sure Wanda shares my struggle. Um, I often don't know what the orthodontist wants as far as almost like taking control of the case.
Okay.
Because I've always been more comfortable of like, you're the orthodontist, like I'm going to give you some insight as to what I may be looking for, but really I don't want to tell you how to do your job. Or try to dictate the terms of what happens. I've always been more of a in a basic scenario, hey, can we level align, coordinate, those words we all throw out. And then usually I'll just throw in things like the patient would likely benefit from a little bit more upper lip projection. So if we can procline upper incisors or retrocline or procline lower incisors, those are the kind of things that I'll throw in. But I think some orthodontists would probably look at my style as saying like, hey, I sent this to you. I really want you to just like send it back and tell me what to do. And then I get the impression that other orthodontists are the exact opposite. So you may not be able to speak to that, but do you have any thoughts on that?
No, I do. And I think I mean, it could vary personality wise, but it also could vary like new grad versus like, somebody in their like 50s or 60s. But I think, I mean, for me, and especially me, this part is probably the new grad part. I really want to hear what you guys are thinking. So it like, to me, I'm not gonna take it as a, like bossing someone around. Like I really want to know, like if you feel like, this is something that you like, I want to know how I can set up the case best for you guys, if that makes sense. I learned some pretty good tips like when I was in residency and we had a couple surgical cases that we each got to maybe hopefully either complete or at least like see through to surgery. So but I think really knowing how I can best set things up, like little things like one of my attendings mentioned that if we don't, get the sevens out of the way, like if you might mess up your guys' ability to set an occlusion really nice, like little things like that, like making sure the models are good and
Wasson doesn't look at the sevens.
I
That's
don't
okay.
he
even know what
just
sevens are.
excludes those for the impressions. Actually, he just plans on taking them out.
Buzzes them off. Okay, sounds good. Okay, well maybe not. But yeah, I think like for like I really want to know like as much as like picking your guys' brains, like I really want to know as much as I can about what you're thinking because I think it helps me not just for the one case that we're working on, but even for the like future cases. And I think knowing how I can best set things up, or if you are saying, oh hey, like I need these more proclined, maybe even just like I would want to know just like the reason, like how does that help you guys? And so I think for me, and maybe just being in a learning standpoint, like I do want to know as much as possible about what you're thinking. And I don't think that comes off badly to me at all. Maybe if somebody's older, more experienced, and they feel like they've been, doing this forever and they don't really need somebody to tell them XYZ of, how they think this should be done, or it could be taken the wrong way, or just they just feel like they don't need it. But I think the more communication, the better was like really my biggest takeaway from UW. And so I think even there were even times where like because you're communicating with the attending, like I didn't necessarily have long drawn out conversations except for we would go to the virtual like surgical planning portion So that was great. I don't know if you guys did that, but we did that. So that was always kind of nice.
They don't do that in Arizona.
Okay, that's okay, got it. But so, well, we did, I think it was the one I had most recently was I got to go to this virtual surgical planning seminar, and we got to, like, I remember seeing it and seeing the simulations and being like, I kind of want a Genio. And Dr. Lang was like, I also kind of want a Genio. And so I remember we were able to play with that around like together. But other than that, we didn't have tons of chatter back and forth about, well, do you think this would be better for the setup or not? And I did feel like the orthodontists that I was working with were great about like giving their input about how, what the surgeons they work for like. But I don't know if that came from them talking to the surgeons like in private practice the way we are now, or if that
Yeah,
just,
I
they're
think it's different on the surgery side, Wasson, don't you think? I mean, because I think it's different on ortho, but also on surgery, because there's spots,
No
and I know
doubt.
spots that are very like specific, and they want like marginal ridge on tooth number 4 intruded a millimeter. I want this bracket repositioned. I feel like there were by my eye, a little bit of micromanaging of orthodontists. And so I think I'm a little bit more like you in terms of, hey, I mean, you guys are professionals like we are. Do your best, get it set up. I can get it sorted out with surgery. But I
Right.
know from surgeons, they're not all like that. I feel like, and I witnessed that firsthand in training, in residency, just how picky people can be with the ortho setups. Um, so I can believe that you saw a little bit of that in residency. Yeah. Like some surgeons just very,
Yeah, I mean, I think I would say that I would say at Children's, we got some exposure to kind of the communication between the orthodontist and the surgeon. Say UW, I didn't feel like there was as much of that because it was mostly Dale and Gary who were in private practice but affiliated with the university. And so like we weren't doing a lot at the university when I was there. And so you're not like along for the ride. You're not seeing cases to completion. You're not seeing that communication. Um, I just remember the big thing that they always talked about then was that Dale always wanted like bands on the sevens and other things. And like that was always what they talked about was like surgeon preference. But beyond that, like I kind of feel like my exposure was similar to what you and I are describing in that like we were just kind of giving some minor input. It would, maybe, hey, I think this is the three piece between the laterals and the canines, or the canines and the first buys, or it's a two piece. And that was really about the extent of what I think I got exposed to in residency, unfortunately.
Did you guys start to like when you got out of residency start to try to get more involved a little bit just so you could like, get a better outcome? Was that kind of what ended up happening?
I think
oh
so.
no,
I mean,
there's
that's
just
always the
different.
goal.
Yeah, no, there's different views on it. It's, at least I see it as the same on the ortho side being involved on the surgical setup. Because like you have different attendings, right, in surgery residency, and some of the attendings would have no problem sending a kid in who's a senior, let's say they're a junior or senior in high school, and they just want to finish up their care, get their sag done on Christmas break, and get their braces off before they graduate. They'd have no problem saying, hey, this upper 5 is out of the arch or needs to be intruded another few millimeters, and you won't be ready until summer, so go back to the orthodontist. Like, and then at the same time, other people are like, hey, I understand. Let's get this sorted out. You've been in braces this long time, independent of the reason for that. Let's get this sorted out in life. And I guess I'm just a little more partial to that. It isn't that I don't want an ideal orthodontic setup. It's just that the setup has more complexity to it than what's the perfect thing, right? I mean,
Right.
because perfect surgically can get you in trouble. There's definitely a saying in surgery, like the enemy of good is better. And I think it's, we all want the best outcome, but there's also other things to consider with those things. And so orthodontically, I mean, over the years, I'm pretty comfortable with a lot of different setups just because, I mean, people show up with a lot of different braces. I mean, lingual ortho or labial ortho or, no ortho, or we're doing ortho after a period of time or doing surgery first. And you know what I mean? Like there's some variety in practice patterns, and I think that just speaks to the different practitioners, right?
No doubt. Yeah.
Okay, I have actually a question. I'm kind of curious. Like, what do you, I know it's kind of broad, but what do you guys want from the orthodontist? Like when you start in a case, or if you're working with like a new orthodontist, what do you kind of want from them in the very beginning or just throughout the process?
I
Or
mean, I
You
like
want
the communication side a lot, actually. I think the planning at the beginning, so we can talk about, so we see the case relatively eye to eye. Because I mean, the hard thing that I'd have is, you know, I find out that people don't know what I'm thinking. I feel like Wasson can read my mind sometimes, but unless I tell him, he won't know. And so, you know, if your perspective on surgery is that it's weird not to have bands on the sevens, and if I say, you know, you ask what do I need, and it's like, I don't, you know, I'm okay with whatever you want to bring. You know what I mean? Like
yeah.
to where we can
That's
honestly
my
talk
struggle.
that,
That's
like, what do
honestly,
you expect out of an ortho setup? And I don't know if I'm, you know, because sometimes it's like, I guess what I'm thinking, but I don't want it to be that way. Because, you know, I want us to both be comfortable with the case. So,
yeah, I think
um,
the communication thing is something we would all say, but I find that kind of what you're saying, Sam, is where I struggle in communicating and where maybe the people that I work with would be like, man, wish this could be better as far as communication, because just like you're saying, like I was trained where we put bands on all the sevens, like you just band the sevens and band the sevens. And it's like, I don't feel like I need that. And if that's harder for the periodontium, if that's harder for the orthodontist, if that's more work and visits for the patient, like I don't think that that drastically alters my outcomes. And like if you need it, or if you have a preference, I can work with either, because like I'm going to put in IMF screws if I need it. I'm going to put in embrasure wires if I need it. Like I don't feel like I'm that particular. I mean, what I do like if we're using braces is hooks.
Okay.
I do like a lot of hooks. That's a personal
Yeah.
preference. But other than that, like that's where I think that sometimes we're going back and forth of like, hey, I wish someone would just say what they want here. And I think that's where I struggle, because like I don't
it's
like
funny
you
because
could
neither
take
of
the
us are saying what we
braces.
want, you know?
Yeah,
Hi,
you
guys.
could
I think
take the
that's why
braces
Sophie's
off.
laughing at us right now.
You
You
didn't
could
tell me.
take the braces off the day before surgery for all I care, like
Okay.
What the hell do you guys
I can
want
do it.
then?
I think the thing I heard the most is that certain surgeons want bands on their sevens. I think like almost every attending would tell us that. There was like and I don't think they even knew if it was still super current or not. But that's funny because that's the thing that was like hammered home in the very beginning. And when I did talk to one,
Probably at the UW for
Yeah.
yeah, it
sure.
was at UW, and then one of the surgeons I talked to was like, I don't care. And so yeah,
Right. I
Yeah,
mean,
I
I
think the
just don't.
communication side. So getting the time to talk and just kind of, you know, just throw things against the wall because, you know, there's always concerns about saying the wrong thing or something of that nature. And I think new into practice, I don't think you can offend people by just throwing things out there. Like,
You hope
you don't
not.
put
I
bands
mean,
on the
I think,
I hope
sevens.
not to.
Malpractice.
yeah, I mean, we're doing clear aligner surgery for what, like coming up on like 10 years. Like, we don't need bands on the sevens. Like, we can work
They're actually kind of
beyond
nice from
these
time to time
things.
on Invisalign cases. I mean, it's not a terrible. Anyway,
Putting
that'll be a
bands on
topic for
sevens
another
during
one.
Invisalign?
Yeah,
What are
yeah.
you even saying right
I think
now?
the other thing I wanted to, I've been meaning to ask you. So, your other ortho residents, like your buddies that you went to dental school with, that went to ortho, or your ortho residents, where are they all going these days? Are they joining practices with their parent, their mom or dad who's an orthodontist? Or are they going to the corporate, or what sort of deals are they doing? Do you hear?
Yeah, okay. So for the ones that have graduated, I think that I feel like there's still this mindset of a lot of people are like, if I can do private, I want to do private, which it's I totally get that. I think I have also been, kind of the mind that there definitely are a lot of people who have gone corporate. And I think to be honest, like even to me, like that's not an unappealing thing at all because I think early on, like it's not bad to walk into something that's just, it's running the way it's running. You get comfortable with the ortho, and later on you can learn the practice management part because I think that's the part that I feel like we just don't learn that much about it early on. But I think people are, if you do have someone, like I have my dad, I think people do tend to go at least part-time in, like, afterwards. But I think, otherwise, just finding, I think the dream that we like, people always kind of want, like the ideal situation is you come out and then find associateship or maybe partnership, but associateship with somebody who eventually will let you partner in. Like that's, I think, what people like shoot for when they come out of
That's
residence.
so interesting for people. Oh,
Yeah,
cool.
but I don't know that that's always what happens. And I think also there's a lot of, at least from what I've seen and from what like we kind of talk about, like, your first job maybe isn't going to be your last job. I kind of hope mine works out, but I think it's this thing of like, you don't know how, like they say, like a partnership is like a marriage, and you don't know how you're going to work with someone. Maybe the style is going to be different. Maybe the personalities don't mesh super well together, or maybe there just wasn't availability, and so corporate made more sense at the time. But I think even if that's like the ideal, the people I've talked to who are in corporate right now are really happy so far. So I know that it varies experience by experience, but I think that's one thing that it was kind of nice to see that it's not necessarily like this one situation is the only one that can work out really well. But I do think mainly people do kind of look for something that will lead to a partnership eventually. That's the kind of the main goal.
Cool.
Nice.
Well, yeah, I think we're coming to the end. Wasson, you got anything else?
No, I'm just appreciative that Sophie came on and gave us some insight, because I'm always perplexed about the orthodontic perspective on these things. And luckily, one of us was willing to ask some hard-hitting questions on this episode.
I had fun. You guys can pick my brain at any time. It's good. It's good for me too. I kind of like the idea, like the chance to kind of hear what you guys are thinking on your end too. And yeah, no, just like talking to different oral surgeons and knowing what's out there that's not even just like from Seattle is kind of a different conversation that I don't get to have very often. So yeah.
It is
Cool.
different out there. It is different places for sure. All right,
Neat.
cool. Well, thanks again. That was another Down Fraction podcast, a podcast for Talking Jaws, downfractionpodcast@gmail.com. Feel free to email us and give Sam ridicule for his softball questions and me for being a complete jerk most of the episode today. And we'll be back next week, right, Sam?
Next week it is. Sophie, thanks for coming on, man.
Thanks,
Yeah,
guys.
thanks again. And
Have a
good
good
luck
night.
in practice.
Thank you. You too.
See ya.